For day 10, I want you to focus on all things respiratory system. So in particular, asthma and COPD. So going through an introduction and pathophysiology for asthma, symptoms, the BTS sign guidelines, NICE guidelines, all the different medications in relation to asthma management. So beta-2 agonists, inhaled corticosteroids, leukotriene receptor antagonists. I'm going through acute asthma management, COPD management, inhaled antimuscarinics, the NICE guidelines for stable COPD, and the common inhalers that are used. So this is named in order of all the topics on the ProPlus platform already. However, if you're a non-member, go in accordance with this with the respiratory system, and I'm going to include some videos on this YouTube video for free.
Hi, my name is Dr. David Wenzel. I'm an ST6 in palliative and internal medicine, and I'm a PhD student with special interest in the end-of-life care needs for patients dying of respiratory failure. And today what I'd like to talk about is asthma. So the way we're going to structure this today is we're going to talk about the pathophysiology of asthma, because it's much easier to understand the aims and purposes of the treatment if we have a good foundation in the pathophysiology. And then we'll talk around the individual guidelines, the BTS and the NICE guidelines, before focusing more specifically on individual drugs, their pharmacokinetics, doses, mechanisms of delivery, and things like that. So first of all, you need to not think about asthma as being a condition of twitchy airways, which is how a lot of people will describe asthma. Asthma is a chronic autoimmune inflammatory condition that is driven by most likely histamine. So what you have is an environmental allergen that isn't an allergen to everybody, but it is to people with asthma. So pollen, for example. That pollen is inhaled into the lungs where it is detected by IgE receptors. IgEs are attached to the side of mast cells, the cells that are responsible for releasing histamine. And this is the same mechanism of action that we see in allergic rhinitis or allergic conjunctivitis. It's all the same thing. The allergen comes in, it's detected by IgEs, mast cells think, oh, this is a pathogen that I need to react to, and they release histamine. And histamine then acts through a number of interleukin mediaries to produce inflammation. And what happens over time is that inflammation drives a hypertrophy and a thickening of the walls of the airway. The mucus cells, the goblet cells that produce your mucus, become more numerous, more able to produce mucus because they're constantly stimulated by this inflammation. The muscles in the smooth airways become much, much, much stronger, much thicker, much more able to close the airway in response to environmental insult. And so what happens is you have an airway that is primed. And that's what asthma is. Asthma is a priming of the airways in response to environmental allergens, but now also primed ready to respond to environmental allergens. So your asthmatic patients were now exposed to things that might make anybody a bit airway twitchy, like very cold air or smoke, are now suddenly in a position to respond much more strongly and much more pathologically to the intensity of that environmental stimulus. So when we expose our airways to cold air, for example, they're going to constrict, they're going to produce much more mucus, and that's going to cause an airway obstruction or a partial airway obstruction, particularly in those small airways that are very, very affected by constriction of smooth muscle. And that's when people say twitchy airway disease, that's what they're talking about, is we have airways in response to sometimes normal environmental stimulus will now become constricted. But they only got that way for a period of chronic inflammatory change. And that's the thing to have in your mind when we go through all of the asthma management, is I'm not here to try and prevent somebody's airway from constricting. I'm here to stop it being in a position where it can constrict so much and in response to so little stimulus. So patients will often present with a period of chronic symptoms from ongoing low-level airway irritation. They'll often be wheezy And now a wheeze is a really tricky thing because people can generate their own wheeze by constricting their glottis, so an upper airway noise. They'll go, and that noise is the noise of a wheeze, except what we're talking about is a lower airway wheeze. So it's a polyphonic, so there's lots of different individual notes to it because it's coming from lots of different sized airways, and it's audible on auscultation. And sometimes if you place your hand on somebody's chest, you'll actually be able to feel them wheezing. We're not talking about upper airway noises, we're just talking about lower airway wheezing. People often have a cough, which is often worse at night, and they may become short of breath exertionally. It's unusual with asthma to be short of breath at rest unless you're having an acute exacerbation. And oftentimes people will complain of chest tightness. That chest tightness is, that sensation is created by afferent sensory fibers in the lungs being stimulated by that ongoing inflammation. So people will come in with a long period of, my breathing's not great when I exercise. I notice when I go to bed at night, I often cough myself awake. My partner says I'm driving insane because I cough and I can wake the whole house up. And I feel tight-chested and a bit wheezy. That's a very classic asthma presentation. If you delve into a little bit more nuance to that history, you'll often see that asthma worsens after exposure to an allergen or an environmental stimulus, which we know and we understand is because we have primed airways. And if you avoid those triggers, things get better. So you may say, or you may have a patient who says, I've been doing some spring cleaning, I've been up in the loft, I've moved lots of things about, there's lots of dust, I got really wheezy, I had a bad cough, I felt really short of breath. But actually, when I went downstairs, when I went outside into the fresh air, things were a bit better, things resolved over the next couple of hours. So that's a very minor exacerbation of your asthma, driven by an environmental trigger that once you remove yourself from, starts to settle down. And lots and lots and lots of people will say, I was asthmatic as a child, but I thought that had cleared up. And there are lots of kids who are wheezy, they have smaller airways, so smaller amounts of inflammation and twitchiness to those airways will produce more symptoms. So very often, people with childhood asthma will grow out of it as they move into adolescence. But actually, they don't really grow out of it. What happens is their airways get bigger. But they're probably still on some level responding to those same environmental pathogens. It's just that it's less noticeable for them. And these people probably have what we might think of as subclinical asthma that doesn't really require treatment, but it does explain an awful lot of those diagnosed in my mid-20s asthma cases, or diagnosed in late teens, early 20s, when people start living in university accommodation, which is often very mouldy. They have more environmental exposure, and that drives their asthma back up to the surface. And then this last point that you'll often pick up with patients is atopy, which refers to people who have the normal spectrum of allergic illness. We know exactly why that is from the pathophysiology. So if you respond to pollen and things in your lungs, you'll probably do it in your nose and in your eyes as well. So you may have seasonal rhinoconjunctivitis or allergies, hay fever, and then of course classically eczema as well. And a lot of the belief about pathophysiology for allergic diseases actually starts with eczema, that chronic inflammation of the skin, providing a breakdown in the skin barrier, enables environmental allergens to come into contact with your blood, and then internal surfaces, I should say, and that then creates an opportunity where the body finds these allergens in your circulation or in your tissues and then develops antibodies against them. And that's what drives the idea that, this allergen that I've been breathing in and out for ages is actually a pathogen, and I need to respond to it with histamine and inflammation because this is a bad thing I need to get out of the body. Whereas actually reality is it's only bad if you respond to it badly. So when we talk about asthma, we'll talk about acute asthma exacerbations and we'll talk about chronic asthma. So an acute asthma exacerbation is an abrupt worsening of your asthma symptoms, which normally would be about over the course of about 6 hours. And it's supported clinically by tests like reduced FEV 1.0, which is the amount of air you can breathe out in 1 second. That's more often tested with spirometry and is a bit tricky to do in clinic or in the emergency department. So we normally talk about the peak expiratory flow rate, or PEFR, and that is when you give them a tube to breathe in and they have to breathe out as hard as possible, and it's the maximum strength of that outwards breath rather than what comes out during the whole second. And your PEFR is something that these patients should be monitoring at home long term, so that we know when it's reduced to be able to correctly diagnose the severity of exacerbations. And the aim of treatment of exacerbations is I just need the patient to be back to where they were. I just need their symptoms to go back to baseline and for their airway twitchiness to settle. Now, longer term, if you've ended up in a situation where you're in hospital with an asthma exacerbation, you have badly controlled asthma, and you have the sort of asthma that kills people. So for those people, once you've returned their baseline function, they need follow-up. They need consideration of how it is that you ended up in hospital with an asthma exacerbation. Chronic asthma management is about managing the hypertrophy of the airways. So we want to protect or improve baseline lung function by reducing inflammation, and in doing so, we take away that airway hyperresponsiveness, that twitchiness that drives the asthma response. I will talk about, just as to get it out of the way, really, there are very few non-pharmacological treatments for asthma. They are all fairly self-explanatory. If you smoke and you have asthma, you are much more likely to die from it. That is the summary point. Patients will do with that what they will. They need to stop smoking if they want to have the best chance of controlling their asthma. Weight loss has been shown to improve breathlessness in asthma, and it makes a lot of sense if you think about it. If you've got slightly inflamed airways, it's difficult to move air through. Having less weight on your chest wall to move, having less requirements for oxygen are helpful to your breathlessness and your work with breathing. So weight loss is a supported treatment for asthma. And there are certain breathing exercise programs that the physiotherapists will teach. Sometimes people with asthma will develop a very dysfunctional pattern of breathing, which is common in people who have chronic breathlessness, and breathing exercise programs to help to control that. And that's the end of this slideshow. I'll do the next section on a different thing. I'll just leave you lots of editing time to fit it with here. Yeah, that's my last slide. Thanks.